Good morning, students. The current theme is continuation of drugs influencing the efferent innervation. These drugs include cholinergic agents and adrenergic agents. Cholinergic drugs are the agents influencing impulse transmission in cholinergic synapses. They include cholinomimetics and anticholinergics. During the last lecture, I delivered cholinomimetics. And now let us discuss about anticholinergics. The first group is M-cholinoblockers. These are drugs, the mechanism of action of which is associated with blockade of M-cholineceptors. Blockade of M-cholineceptors causes different effects in our organism. In the CNS, decrease of mental work. This is of course side effect. Reticular formation, sedative and hypnotic effect. Sometimes we use the agents with expressed central activity as sedative, tranquilizers and hypnotics. Limbic system. Blockade of M-cholineceptors causes decrease of emotional sphere, tranquilizing effect. Sometimes we use striopalliidal system. Blockade of M-cholineceptors helps in control of movement coordination. That's why we can use central M-cholinoblockers for treatment of Parkinson's disease. The vestibular analyzer. Blockade of M-cholineceptors causes elimination of vestibular disorders. That's why sometimes also central M-cholinoblockers used for treatment of motion sickness or for prevention. Let's continue. Effects. The eye. Influence on the eye. So blockade of M-cholineceptors of circular muscle causes relaxation. You see relaxation and dilation of pupil, so-called mydriasis. And because of mydriasis, photophobia. Photophobia, of course, this is side effect, but mydriasis can be used for examination of eye fundus. We drop the drug into the eye and in several minutes it's more comfortable to investigate eye. And also for prevention of adhesions formation between iris and lens in traumas of the eye, in inflammatory diseases. For prevention we cause dilation of pupil. But besides photophobia, dilation of pupil mydriasis promote increase of intraocular pressure. This is side effect. That is why M-cholinoblockers principally are contraindicated in patients with accompanied disease of the eye, glaucoma. For patients with glaucoma, these drugs are contraindicated. Let's continue. M-cholineceptors localized not only in circular muscle but also in ciliary muscle. And blockade of these M-cholineceptors causes tightening of Zinn's ligament, decrease of curvature of the lens. the eye sets for distant point of vision. This is called paralysis of accommodation. Paralysis of accommodation means lens is not able to change curvature. Stop of accommodation. For what can we use this? We can use for selection of spectacles. It's first. And for treatment of spasm of accommodation, specific condition, to provide repose of the ciliary muscle. The ciliary muscle. So we can use M-colon blockers once again for dilation of pupils. We use for investigation of eye bottom and for prevention of adhesions formation, and also for selection of spectacles and for treatment of spasm of accommodation. But if we want to investigate eye or to select spectacles, this procedure is short, 15-20 minutes, not more. And we need the agent with short action duration upon the eye. But if we need to prevent formation of adhesions in trauma, for example, of the eye, or to treat spasm of accommodation to provide repose, this is long treatment. That is why, for this case, we should use M-colon blockers, local M-colon blockers, eye drops, with long action duration. Long action duration. Let's continue. In the heart, blockade of M-colon receptors causes increase of excitability, acceleration of conductivity. Sorry. That is why we can use M-colon blockers for treatment of cardiac blockades and cardiac arrest. Cardiac arrest. Smooth muscles of inner organs. During previous lecture, we discussed that stimulation causes increase of tonicity, peristalsis, and we should understand that blockade of these receptors causes decrease of tonicity and peristalsis of smooth muscles. All smooth muscles, GIT, bronchi, biliferous, urinary tract, eye, just now we have discussed, because circular muscle and ciliary muscle are smooth muscles. That's why their tonicity also decreased. But increase of sphincter tonicity. That is why we can use M-colon blockers as antispasmodics for treatment of intestinal, biliary, and urinary colics. Colic means pain caused by spasm of smooth muscles. Bronchial asthma. We will study with you in a few weeks that other drugs, adrenomimetics, are used very often for this, but advantage of M-colon blockers versus adrenomimetics, inhibition of bronchial gland secretion, and relaxation and inhibition of secretion. Same effect, decrease of uterus and cervix tone in labor if necessary. But we understand that this effect can cause, of course, undesirable action. After usage of M-colon blockers, constipation can develop. Let's go on. Exocrine glands. Mimetics cause activation of secretion, so blockers, M-cholinoblockers, decrease secretion of all glands. Glands of GIT, bronchial, sweat glands, and other. It ensures usage for treatment of hyperacidic gastritis, gastric and duodenal ulcer accompanied by increased secretion of HCl, pancreatitis, for decrease of salivation during dental manipulations, for premedication before general anesthesia, and in bronchial asthma. Bronchial asthma. So we use influence on exocrine glands. But we should understand that sometimes this effect is undesirable. That's why it can cause dryness in mouth, side effect, hyperemia of skin because of inhibition of sweating, increase of body temperature. And now classification of M-cholinoblockers. Classification. First of all, we distinguish two groups by the origin. Plant origin or alkaloids and synthetic drugs. What does it mean, alkaloids? Alkaloids is one of the class of the group of plant origin molecules. The plants can produce a lot of groups, different groups. One of group is alkaloids. These molecules have nitrogen and basic origins, weak basic origin. The alkaloids are atropine, this is classical agent. That is why M-cholinoblockers can be called atropine-like drugs. These are synonyms, M-cholinoblockers or atropine-like drugs. Hyoscine, hyoscyamine, platyphylline. And synthetic drugs. You see methacinium, ipratropium, pyrazine, dicyclamine, darifenacin, and so on. What does it mean? Tertiary means quaternary. Once again, last time we discussed tertiary means nitrogen has 3 valencies. This nitrogen is non-polar, neutral. That is why these molecules are neutral. That is why lipid soluble. That is why can penetrate through different membranes, including barriers. Also, these agents, of course, better penetrate through hematoencephalic barrier. Synthetic drugs are quaternary ammonium compounds. It means there are 4 valency nitrogen with plus. That is why these molecules are polar. Molecule has N plus and minus. These molecules, polar, are water soluble. That's why less penetrate through barriers. That's why these agents are predominantly of peripheral influence. But atropine and the rest act and on peripheral organs and on the CNS. Classification by selectivity. Central cholinoblockers. First group, central. Central means those which have influence on CNS. But we should understand that it's impossible to influence only on CNS, because the drug after introduction first act in peripheral circulation, acts on peripheral organs, and after penetration through hematoencephalic barrier acts on the CNS. We should understand that for these drugs characteristic are both and peripheral and central effects. Central effects. Next group. Peripheral cholinoblockers with resorptive action. With resorptive action. Atropine, platyphylline, metacinium. They are used for influence on different organs. And exocrine glands, and smooth muscles, and heart. But just now we discussed that atropine belongs to tertiary amines. That's why atropine can penetrate into the CNS. Yes, of course. So atropine influences and on peripheral organs and on the CNS. Next group. Peripheral cholinoblockers with local action. Local. This is resorptive, this is local. Why local? Because these agents act only locally. They poorly penetrate through membranes. Exactly these drugs are used for bronchial asthma. Not obligatory attacks for prevention, but for bronchial asthma. But because ipratropium bromide, tiotropium bromide, umeclidinium bromide, and cyclopyrronium bromide are produced in the form of spray, aerosol or spray. And a patient should inhale these agents. That is why they act only in airways. And they are poorly absorbed. That's why no influence on the rest organs. That is why we use for bronchial asthma. Ipratropium is the first one. It has shorter action duration and used 2 to 3 times daily. The rest act 24 and more hours. That it's enough one inhalation for 24 hours. Peripheral cholinoblockers with local action used as eye drops. These agents are produced in the form of solution for eye drops. Homatropine tropicamide should be used only for the eye. But for the eye, we also can use atropine solution, hyoscine solution, platyphylline solution principally. But we see that these agents can be used for influence on different organs and also in the form of eye drops. Homatropine tropicamide used only in the form of eye drops. Exactly these two agents have shorter action duration. The shortest, tropicamide, action duration approximately 6 hours. Homatropine, 24 hours, 24 hours. Comparatively to atropine, one instillation, one application of a drop of atropine for the eye causes effect for 3, 4, 5, 6 days. 6 days. We should understand, if we need short action, for example, investigation of eye bottom or selection of glasses, spectacles, of course we should use tropicamide. If we need long acting drug, atropine, hyoscine. All these drugs are non-selective, and central and peripheral non-selective, because they influence they block different kinds of M. cholineceptors. We distinguish M1, M2, 3, 4, and 5. All these drugs non-selectively block all M. cholineceptors. But next group, selectively blocking gastric M1 cholineceptors, pirenzepine. Why M1 receptors localized in stomach? Basic localization of M1 receptors is formations of nervous system in CNS, in presynaptic membrane of ganglions. Why in stomach? Why in stomach? M1 receptors localized in special cells of gastric mucosa, enterochromaffin-like cells. In enterochromaffin-like cells, the role of these cells helping in release of HCl. These cells, enterochromaffin-like, are innervated by vagus nerve. And vagus nerve stimulation causes release from these cells histamine. And histamine stimulates H2 histamine receptors on parietal cells of gastric mucosa that causes increase of release of hydrochloric acid. That is why blockade of these M1 cholineceptors decreases secretion of hydrochloric acid. Decreases. Why selectivity is only for stomach? Because in all the rest organs there are no M1 receptors, or M3 receptors, or M2 in the heart. For example, we use pirenzepine for ulcer of stomach to decrease secretion of HCl. But we can use atropine, platyphylline also. But if we would use platyphylline, metacinium, yes, they cause decrease of gastric secretion of HCl, decrease of acidity, but at the same time they cause tachycardia, dryness in mouth, inhibition of peristalsis of intestine. All of them are side effects, non-necessary effects. And all of them also cause influence on the eye. They can promote increase of intraocular pressure and can cause impairment of vision. These are side effects. Pirenzepine doesn't act on heart, on intestine, on salivary glands, on eye, because act only on M1, localized or in CNS or in stomach. But penetration in CNS is poor. That is why this is gastro-selective M. cholinoblocker. And the last group, selectively blocking M3 cholineceptors. M3 localized in smooth muscles of GIT, bronchi, and so on. And also in exocrine glands. But these agents, darifenacin, oxybutinin, solifenacin, tolteridine, and fesoterodine, are used mostly for action on urinary bladder. And they are used to treat hyperactivity in polyurination. If a patient urinates very often, this is hyperactivity, we use these drugs. They promote relaxation of smooth muscles and accumulation of more urine. So these drugs are used selectively for disease of urinary bladder. What else? Hyoscine. can be used for pre-medication, pre-anesthetic medication. What is the purpose of use of M-colon blockers for medication, pre-medication? Pre-medication means usage 30-40 minutes before operation with general anesthesia, before general anesthesia. Why? Because most of general anesthetics, especially inhaled general anesthetics, cause reflex activation of secretion of salivary glands, bronchial glands, reflex reaction, disturbing to operation. To prevent hypersecretion, we use one injection 30 minutes before operation of M-colon blocker. But why do we use hyoscine? Yes, hyoscine prevents hypersalivation, hypersecretion, but at the same time, having central activity, it causes inhibitory influence on CNS. That is why the interaction with general anesthetics is synergism. And using hyoscine, we prevent hypersecretion, but also promote positive interaction with general anesthetics. And in this interaction, we can use a little less dose of general anesthetics for essential level of anesthesia. This is very positive, very positive. Platyphylline. Platyphylline is interesting, is of plant origin, but it is interesting by special additional ability to influence on smooth muscles. First of all, like all the rest M-colon blockers, blocking M-colon receptors, they decrease tonicity of smooth muscles. Yes, but there is the second mechanism of action of this drug. It inhibits phosphodiesterase in smooth muscle cells. That causes, because of influence within smooth muscle cell, not on extracellular receptor. So the drug acts and on extracellular M-colon receptors, and the drug penetrates in the cell and within the cell inhibits phosphodiesterase. That causes additional relaxation of smooth muscle. So, for treatment of different spasms or colics, this agent is more preferable. More preferable. Okay. These are plants: Atropa belladonna, Hyoscyamus niger, Datura stramonium, which basic alkaloid is atropine. Atropine. I told you that this is atropine group or atropine-like agents. Name of atropine is because of name of plant, Atropa belladonna. So this is basic alkaloid. Atropine is principally toxic. Toxicity is high. And sometimes people can be poisoned using leaves, for example, of these drugs, or berries of these plants, especially children. If children eats berries of these plants, he is poisoned, and of course we should treat him. That is why we should understand what are the symptoms of poisoning or symptoms of overdosage of atropine. Same symptoms will be. They are psychomotor excitement, delirium, hallucinations. Psychomotor excitement, delirium, hallucinations. If we look at the eye, we see significant dilation of pupils, mydriasis. And a patient doesn't want to look at light. at light because of photophobia. And tears, looking at light, tears from the eye. Next, tachycardia, expressed tachycardia. Next manifestation, dryness in the mouth, and that is why impairment of swallowing and hoarse voice because of insufficiency of saliva. Dryness of skin because of insufficiency of sweating. This causes hyperemia of skin and increase of body temperature. These are manifestations of poisoning by atropine or atropine containing plants. What should we do for treatment? Of course, we shouldn't forget about general measures always. General measures means washing of stomach, cleansing enema, intravenous infusions for disintoxication. We use so-called forced diuresis. What does it mean, forced diuresis? We shouldn't understand that this is only activated diuresis. This is manipulation for detoxication, and it includes two stages. First stage is hemodilution. We dilute blood introducing low molecular solutions like neohemodes, 5% glucose or dextrose solution. Why low molecular? Because these molecules should be filtrated in kidneys and evacuated, excreted from the organism, together with molecules of toxic substances. So we introduce 1.5, 2 liters, and after we introduce intravenously strong diuretic, for example, furosemide. And in 1, 2, 3 minutes, we investigate activated diuresis. If we have introduced 2 liters, but a patient excretes 5 liters, for example, of urine, this procedure is called forced diuresis. Previous lecture we have discussed about poisoning by cholinesterase inhibitors, and I told you that there are specific antagonists. Specific means used exactly in this poisoning. Yes, for cholinesterase inhibitors we have specific antagonists, but for atropine we don't have specific antagonists, because affinity of atropine to M cholineceptors is very high. Atropine can be helpful in poisoning by any M cholinemimetic, cholinesterase inhibitor, but not on the contrary. If atropine is introduced, it tightly binds to receptor, and no one agent can stop this interaction. That's why principally no specific. Sometimes we use cholinesterase inhibitors penetrating into the CNS as antagonist. Sometimes this is helpful. For example, physostigmine. So if we investigate expressed manifestations from the site of CNS, hallucinations, delirium, we can introduce cholinesterase inhibitors, physostigmine, and like physostigmine. They cause inhibition of cholinesterase, accumulation of acetylcholine, more of acetylcholine promote shortening of influence of atropine. The rest are symptomatic measures. Cooling of the body. In psychomotor excitement, we also use agents with inhibitory influence on psychical sphere: barbiturates, diazepam, chlorpromazine. In expressed tachycardia, we use beta adrenoblockers. And now, please break for 10 minutes. Let us continue our lecture. Let us continue. So, next group of anticholinergics, are N-cholinoblockers. N-cholinoblockers. They include ganglionic blockers and peripheral myorelaxants. Last time we discussed that N-cholinereceptors, nicotinic cholinereceptors, are divided by two groups: N-neuronal, basic localization in vegetative ganglions. So the drugs blocking N-neuronal are called ganglionic blockers. And second localization, N-muscular, in skeletal muscles. So the agents binding or acting at N-muscular receptors in neuromuscular synapses cause impairment of contraction of the skeletal muscles, inhibition of contractions. That's why called peripheral myorelaxants. So ganglionic blockers and peripheral myorelaxants. Ganglionic blockers. We have discussed this scheme. This is parasympathetic arc, including two neurons, central and ganglionic. And sympathetic arc also includes central neuron and ganglionic. Both in parasympathetic and sympathetic ganglions there are N-neuronal cholinereceptors. And ganglionic blockers blocking these receptors cause inhibition of both parasympathetic and sympathetic influences on all internal organs. It's possible to say that usage of ganglionic blockers is a like chemical or medicinal blockade of vegetative ganglions. Classification of these agents. First of all, by the chemical structure. Again, we see polar and non-polar. Yes, polar agents, water-soluble, poorly penetrating through hematoencephalic barrier. They include quaternary ammonium compounds and also sulfur-containing agent. Quaternary ammonium compounds are azametonium, hexametonium, trypirium, or trypirium maybe. Sulfur-containing agent, which is polar, trimetaphan. And second group, non-polar substances passing through hematoencephalic barrier, and in overdosage they can cause tremor and convulsions. Tertiary amines, pempidine, pekicarpine, and secondary amine, mecamylamine. By duration of effect, we distinguish three groups. First, with long action duration, more than 8 hours. Tertiary amine, pempidine. This agent is well absorbed in GIT and can be used for resorptive action, Sometimes we use its ability to inhibit gastric secretion in gastric and duodenal ulcer. And also the drug blocking sympathetic ganglions causes dilation of arteries and decrease of arterial pressure. That's why principally it's possible to use it for treatment of arterial hypertension. But last years the drug is used rarely. With middle or intermediate action duration, acting 3 to 4 hours, quaternary ammonium compounds, azametonium, hexametonium. If quaternary, it means they are poorly absorbed. That's why used mostly in injections. But injection should be subcutaneous or intramuscular and carefully intravenous. Because in intravenous introduction, action is very strong. This can cause sharp decrease of arterial pressure and orthostatic hypotension. These drugs sometimes is used for treatment of hypertensive crisis, malignant arterial hypertension, obliterating endarteritis, Raynaud's disease, brain and pulmonary edema caused by arterial hypertension. And third one, picocarpine. Picocarpine is tertiary amine, acting a little longer, up to 5 to 6 hours. Picocarpine, it belongs to so-called atypical ganglionic blocker because its activity on ganglionic receptors is non-significant. But we use stimulating activity on uterus. It stimulates rhythmic contractions and can be used for stimulation of labor. And the third group by duration of effect, agents with short action duration, acting 10 to 20 minutes. They include quaternary ammonium compound trypirium and sulfur-containing trimetaphan. They are not absorbed in JT, that's why introduced intravenously. But because of short action, they are used by drops. So, if we introduce bolus for one introduction, the agent acts 10 to 20 minutes. If we introduce by drops, action lasts until we stop infusion. So if necessary to act for 60 minutes, we should drop 60 minutes. And after stop of dropping, action is over in 10-15 minutes. It's very comfortable. We can use for hypertensive crisis and also for controlled hypotension. This is surgical manipulation, controlled hypertension. We artificially, using the drug, decrease normal arterial pressure, not hypertensive condition, normal arterial pressure, and we artificially decrease from 120 to 190 systolic pressure, 100 to 90 millimeters hydrogerum. For what? We use in surgical practice to decrease hemorrhage. While cutting, so surgical manipulations are accompanied by bleeding, of course. And the level of bleeding is associated with level of arterial pressure. The more arterial pressure, the more bleeding. That is why if you want to diminish bleeding, we artificially decrease arterial pressure for period of operation. And after operation, we restore normal level of arterial pressure. Principally, we can use different ganglionic blockers with different action duration, but the best of all, of course, short-acting. Short-acting by drops, and after stop of manipulation, we stop dropping, and in 10, 15, 20 minutes, arterial pressure is normal. It's very comfortable. It's very comfortable. Typical side effect of ganglionic blocker is orthostatic hypotension. Orthostatic hypotension, or sharp decrease of arterial pressure in changing of body position from horizontal to vertical. In normal condition, when we lay after we stand, we change body position, and principally nothing happens with us. Nothing. But when we stand up, blood falls down. But why? There is no change of blood supply of upper localized organs, of the brain and so on. Why? Because in change of body position, sympathetic reflex is activated, and because of this activation, in lower extremities arteries are narrowed, in upper part of the body arteries are dilated. This is accompanied by tachycardia. That's why level of blood supply is sufficient. Once again, because of activation of sympathetic innervation, sympathetic reflexes. But ganglionic blockers, blocking both parasympathetic and sympathetic ganglions, of course, they inhibit sympathetic reflexes. That's why, if we first introduced ganglionic blocker, so we should understand that arterial pressure is decreased because of dilation of arteries. So, if a patient lays, arterial pressure is a little decreased, but after a patient wants to stand up, he stands up, and blood really falls down. And because of blockade of sympathetic nerves, no sympathetic compensatory reflex, that's why it is accompanied by insufficiency of blood supply of the brain, and patient falls down. Loss of consciousness and different unpleasant reactions. What should we do? We mustn't use any drugs. We should inform the patient about this, and for period of action of these drugs, a patient shouldn't change body position. Or if it's necessary to stand up, it's necessary to change position very gradually to prevent orthostatic or postural collapse. Besides orthostatic hypotension, ganglionic blockers can cause atony of intestine, slight impairment of vision. These are typical side effects, and principally ganglionic blockers nowadays are used rarely. And now peripheral myorelaxation drugs, or skeletal muscle relaxants. Classification. Skeletal muscle relaxants, it means that agents relaxing skeletal muscles. So, classification by the mechanism of action. First group, non-depolarizing or curare-like drugs. Second group, depolarizing. And third one, drugs with combined action. non-depolarizing or curare-like. Why curare-like? Because all of them are derivatives of poison curare. This is alkaloid of special trees from South America, tropical tree, condodendron. With the help of this poison, South American Indians were hunting and warring. Because when they moisten weapon, arrow for example, with this poison, and after shoot it at animal, in several seconds skeletal muscles were relaxed, and it's possible to take this animal. Curare-like. Curare-like drugs or non-depolarizing are divided by 3 subgroups by duration of action. Acting 15-20 minutes, short acting, myvacurium. Acting 20 to 60 minutes, tubocurarin, pancuronium, cisatracurium, atracurium, vecuronium, rocuronium, and melictin. Sorry, not melicin, melictin. And the third group, acting more than 60 minutes, up to 3 hours, pipocuronium, doxacurium, and metocurin. The mechanism of action of non-depolarizing is associated with blockade of muscular and cholineceptors. Somatic nerve innervating skeletal muscle releases from nerve ending acetylcholine. Acetylcholine interacts with an muscular receptor that causes depolarization and repolarization or formation of action potential in membranes of skeletal muscle cells that causes muscular contraction. Non-depolarizing agents take this place, bind to N cholineceptors. That's why prevent to interaction with this receptor of acetylcholine. That's why no excitation of receptor, no contraction, relaxation of muscles. Mechanism of action of depolarizing succinylcholine is associated also with the interaction of N cholineceptor. But unlike non-depolarizing agents, succinylcholine interacts and specifically stimulates receptor, causing depolarization, but without fast repolarization. So the drug causes long depolarization, and the cell membrane, being in this phase of depolarization, is not able to feel influences of acetylcholine. Refractory period. That is why during this refractory period, which lasts 7, 8 to 10 minutes, acetylcholine is not able to cause relaxation. what is the difference between non-depolarizing and depolarizing? Non-depolarizing are direct antagonists with acetylcholine. Their antagonism is because of influence on N cholineceptor. Acetylcholine stimulates N cholineceptor. Non-depolarizing myorelaxant blocks N cholineceptor. This antagonism is direct and competitive, or two-way. If this is depolarizing agent, so they are not antagonists with acetylcholine. They cause stimulation like acetylcholine, and that is why when we investigate this patient, after introduction of non-depolarizing, we investigate nothing besides relaxation. If we investigate patient after depolarizing succinylcholine, we investigate weak muscular contractions of separate fibers, and after relaxation of all muscles. But interaction for receptors is not antagonistic. That is why in overdosage of these drugs, but overdosage is associated with relaxation of the whole body skeletal muscles, including diaphragm. This is accompanied by respiratory standstill, stop of respiration. Very dangerous complication. So, in overdosage, we should restore impulse transmission. If we have used non-depolarizing, antagonism is two-way or competitive. We can use specific antagonist, which is cholinesterase inhibitor. So our purpose to increase concentration of acetylcholine. The more acetylcholine, the less binding of non-depolarizing to N cholineceptor. So in overdosage, stop of breathing, we introduce cholinesterase inhibitor, which inhibits enzyme cholinesterase that causes accumulation of acetylcholine, increased concentration of acetylcholine in synapse, and stop of action of non-depolarizing myorelaxant, or restoration or contractility of skeletal muscle, and restoration of breathing. So we have specific antagonist. But if we have used depolarizing, we don't have specific antagonists, and accumulation of acetylcholine is not helpful, but on the contrary is dangerous. That is why we don't have specific antagonist. And the last, dioxonium, the drug with combined action. Two phases. First phase is depolarizing block, and after depolarizing block, second phase, non-depolarizing. But principally dioxonium is used very, very rarely. More often we use non-depolarizing or succinylcholine. Why succinylcholine? If it is dangerous, because we don't have direct antagonist. Why? Because succinylcholine acts for 7 to 10 minutes. And in 7 to 10 minutes, its action is stopped. So if we will make artificial ventilation, so this will be last for 10 minutes. It's not so problematic. So we use succinylcholine because of short period of effect. Sometimes it's very comfortable. It's very comfortable. These agents we use because we have antagonist and we have different action duration. So if we need short action, we use or succinylcholine or non-depolarizing first group. If we need long action duration, we use another drugs. So we can choose. We can choose. Skeletal muscles are relaxed by special order. Special order. When we introduce smaller dose, it causes relaxation of facial muscles. Facial muscles of face. If a little more dose, muscles of neck and larynx are relaxed. More dose causes relaxation of extremities skeletal muscles. More dose, muscles of trunk are relaxed. The most dose, diaphragm is relaxed. And we understand this is accompanied by stop of breathing. So the range from the dose when my relaxation begins to the dose when diaphragm is relaxed is called breadth of myoparalytic action. Breadth of myoparalytic action. The more this breadth, the less toxic, less dangerous the drug. The drug. For what do we use these drugs? First of all, trachea intubation. Trachea intubation. Or for artificial ventilation, or for inhalation general anesthesia, we should introduce tube in trachea. And sometimes it's very difficult, especially in sportsmen and in big men and women. It's very difficult because of expressed musculature in the area of neck. That is why we introduce small dose, cause relaxation of muscle, and introduce the tube. Full stop. But we need for this 2 minutes. That is why we need short action. For example, succinylcholine is very good for this. Reposition of bone fragments and treatment of dislocation of joints. Sometimes impossible to repose fragments of bone or to treat dislocation of joints because of strong contraction of musculature. For relaxation of muscle, we use skeletal muscle relaxant. For surgical operations on abdominal cavity organs, for example, we use peripheral muscle relaxants to prevent bleeding during separation of muscle before peritoneum cutting, separation of muscles. Sometimes we used for urgent treatment of convulsions in tetanus, in poisoning by strychnine. Sometimes for treatment of spastic paralysis in urology, the agent mellictin. But we should understand that it's possible to use these agents only being at the surgical department or resuscitation department. So we have to have special equipment for artificial ventilation. Without this equipment is prohibited to use these skeletal muscle relaxants. Side effects of these drugs. For non-depolarizing, characteristic is arterial hypertension. For depolarizing, hypertension and tachycardia. and treatment of overdose, we understand that we should do artificial ventilation, but at the same time, if these are non-depolarizing, we introduce cholinesterase inhibitors. If depolarizing, we should do artificial ventilation, but if stop of breathing lasts for a long time, we use blood transfusion, because succinylcholine is alike acetylcholine, has esteric bonds and is metabolized, but esterases. In donor blood, especially plasma, in donor's plasma, there are a lot of pseudocholinesterases, and they help to destroy succinylcholine and to stop its effect. Adrenergic drugs. So cholinergic drugs are those which influence impulse transmission in cholinergic synapses, and adrenergic are the agents influencing impulse transmission in adrenergic synapses. Once again, this scheme, parasympathetic nerve, first impulse transmission in ganglion, acetylcholine. Second impulse transmission from postganglionic nerve to effectory organ, also acetylcholine, both cholinergic synapses, so cholinergic drugs act in parasympathetic nerves. Sympathetic, central neuron is cholinergic, so in ganglions, for action on ganglions, we use cholinergic ganglionic blockers, but second ganglionic neuron is adrenergic. It means in neurons it's synthesized noradrenaline, and in synapse to effectory cells noradrenaline is released. So adrenergic drugs act there where organs are innervated by sympathetic nerves, in synapses between postganglionic sympathetic nerve and cells of effectory organs and tissues. Exactly here. First of all, it's necessary to revise the work of adrenergic synapse. Let's compare synthesis. When we discussed cholinergic synapse, I told that acetylcholine is synthesized for one reaction. Choline plus acetic acid, there is acetylcholine. But to synthesize final mediator noradrenaline, it's necessary to pass 1, 2, 3, 4 reactions. For adrenaline, 5 reactions. Should be 5 enzymes and 5 portions of ATP. It's very costly for the organism. That is why the fate of adrenergic mediator, noradrenaline, is different than the fate of acetylcholine. Acetylcholine interacts with the receptor and is destroyed. Partially for 25%, reabsorbed to nerve ending. But noradrenaline is reabsorbed for 80%. It's very important. Chemical structure. So first phenylalanine, after plus hydroxyl tyrosine, after double hydroxyls dioxyphenylalanine, and this ring is called catechol. pyrocatechin or catechol. That's why this chemical structure is called catecholamine. Dopamine, catecholamine. Noradrenaline, catecholamine. Adrenaline, catecholamine. But all of them are called monoamine, monoamine, because one NH2 group, monoamines, catecholamines. And this is the structure of some adrenergic, adrenomimetics, very close to chemical structure of noradrenaline and adrenaline. You see ephedrine, very close but without hydroxyls, phenylephrine, one hydroxyl, and isoprenaline is very close. So adrenomimetics have chemical structure very close to noradrenaline and adrenaline. And now, once again, noradrenaline is final molecule in nerve endings. Because in nerve endings, it's not enough of special enzyme, phenylethanolamine and methyltransferase. That's why in synapses, 98% noradrenaline is released and 2 to 3% adrenaline, no more adrenaline. But in medullary substance of adrenals, adrenal medullary, enough of this enzyme. That is why in adrenals there are both mediators, both molecules, and noradrenaline and adrenaline. So after activation of sympathoadrenal system, not sympathetic, sympathoadrenal, this is one and the same, but it's better to call sympathoadrenal. Sympathoadrenal system includes sympathetic nerves, but also medullary substance of adrenals. In activation of this system, noradrenaline is released in synapses, and both noradrenaline, adrenaline from medullary substance of adrenals released into the blood. So, first reactions of synthesis take place in exoplasm. And only last reaction, conversion of dopamine to noradrenaline, takes place in vesicle. First, dopamine should penetrate into the vesicle after it's been transformed into noradrenaline. And in these vesicles, there are no enzymes participating metabolism of noradrenaline. That is why this is stable fraction. It is synthesized and not cleft. In vesicles, stable fraction containing 60% of noradrenaline. In exoplasm, there is special enzyme monoamino oxidase, oxidizing monoamines. That is why if monoamines there are in exoplasm, they are metabolized by this enzyme. That is why this fraction of noradrenaline is called labile fraction, 40%. But excitation from the CNS causes release of noradrenaline from vesicles and after from nerve ending. And during this short period, several molecules can be metabolized. So, this is nerve ending and noradrenaline is released and interacts with adrenoreceptors on postsynaptic membrane. But adrenoreceptors localized not only on postsynaptic membrane, this is first localization, but also we see on presynaptic level. And also they can be localized out of synapses in effector cells which are not innervated. They are alpha 2, beta 2. So alpha 1, beta 1 on postsynaptic membranes, and alpha 2 presynaptically and extrasynaptically, beta 2 also presynaptically, extrasynaptically. What is the role? Role of postsynaptic and extrasynaptic receptors is to feel, to bind with mediator, with noradrenaline. For what? For change of function. Noradrenaline excites receptor, for example, beta 1 of heart, it causes tachycardia. So this is function of postsynaptic and extrasynaptic receptors. What is the role of presynaptic, alpha 2, beta 2? They participate physiologic regulation of release of mediator. Alpha 2 excited by high concentration. If it's more of noradrenaline is released, of course noradrenaline stimulates these receptors, but at the same time these receptors, and by negative feedback release of noradrenaline is decreased. So alpha 2 participate negative feedback mechanism. High concentration excites alpha 2, this leads to decrease of release. Low concentration interacts with beta 2, and this causes by positive feedback increase. So beta 2 participate positive feedback mechanism. More of noradrenaline in synapse, negative feedback via alpha decreased. Low amount of noradrenaline, positive feedback via beta 2, again increase. And all time a little decreased, a little increased, but physiologic diapason of noradrenaline. We should understand it because the drugs influence on all these receptors. That's why they can interfere with mechanisms of feedback, and we should understand action of these drugs. So what is the fate of noradrenaline? It is released, interacts with postsynaptic receptors. In synaptic slit there is one more enzyme, COMT, catechol orthomethyltransferase, participating metabolism of noradrenaline. But only 20% of released noradrenaline is metabolized, but 80% are reabsorbed or reuptaken and pass to vesicles to increase stable portion of noradrenaline, 80%. And what are the targets for adrenergic drugs? First of all, adrenoreceptors, yes. Second, enzymes participate in metabolism. MAO here and COMT here. There are drugs influencing on MAO and on COMT. After, transport systems of vesicles and transport system of presynaptic membrane. For example, it's possible to inhibit transport system of presynaptic membrane that causes inhibition of reuptake and increase of loss of noradrenaline. For today, the lecture is over. Goodbye.